As we delay, our patients are suffering.
We're dealing with an issue in people that didn't do anything to make them this way.
To my mind, keeping people healthy until they can get a more effective treatment should be a high priority.
When you're diagnosed with alpha-1 and you realize that every cold or chest infection you have can cause lung damage, I can assure you that every time somebody coughs around you, you just like...
It's gut-wrenching, you know, it's very depressing. Treatment does mean you can continue your life in a normal manner, and you don't have to fear everything ending in 5 to 10 years.
So we'd really like to forestall all of that, prevent all of that with augmentation therapy.
I find it hard to explain why treatment is not offered to people, or why they don't have access to it, quite frankly.
If my treatment were to stop, my biggest fear, of course, is the lung function declining, and eventually to the point where my lungs just won't work anymore. And I don't even know what my future looks like right now.
I had all these plans to buy a house and have a family and stuff, but we're in Edmonton and I have alpha-1 antitrypsin deficiency. I just thought I was out of shape and it would get better. I didn't want to go just because I knew I'd miss a bunch of time at work, and got my blood test, and yeah, they found out then that I had alpha-1 antitrypsin deficiency.
I did speak to some of my colleagues that I used to work with, and 1 or 2 of them had heard of it. They'd come across it in the hospital, treating patients with this condition. But even then, the majority of the people I've spoken to have never heard of it before.
I think even the benefits person was very surprised that there was no other avenue for me other than moving and upending my life in order to go get coverage in another place in Canada.
And people shouldn't really be kind of made to feel that it's their fault. There should be options. It's definitely something that needs to be looked at as soon as possible. You know, national coverage is crucial.
I have no control. That's, I think in my mind, that's the hardest part. I have controlled everything that I can. My health, my activity level, my food, everything. And the one part I can't control is the treatment. And I have no way of doing that other than to move and leave my family behind.
Good morning. Hello, I'm Gary Murphy, and I'm an alpha-1 patient, and I'm the proud chairperson of the Alpha-1 Antitrypsin Deficiency Canada Board of Directors. Today's event will be taking place in Calgary, Alberta, and I would like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta. The city of Calgary is also home to the Métis Nation of Alberta. Acknowledging the land helps us remember that this was and is Indigenous land and people's homes. We acknowledge that we are on traditional territories in Alberta for the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the land, which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and the First Nations people that call this nation home. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we can each, in our own way, move forward in a spirit of reconciliation and collaboration. Before I introduce Angela, I would be remiss if I did not expand upon the collaboration that has taken place in recent years with our provincial and territorial governments, and also that of Canadian Blood Services. The work that has been done on behalf of the Canadian Alpha-1 patient community cannot be overstated. On behalf of the Alpha-1 Canada Board of Directors, I would like to thank all of our stakeholders and industry partners that have had an unwavering commitment to meeting the needs of the Canadian Alpha-1 patients. Now, if you would please welcome Angela Diano, our Executive Director, who epitomizes the unwavering commitment to meeting the needs of the Canadian Alpha-1 patients. Angela.
Good morning, everyone. So if I don't look up a lot this morning, it's an attempt not to get emotional today. So good morning and good afternoon to everyone joining us in the East. Today we're celebrating a new era for Canadian Alpha-1 patients. I have actually imagined this day for over 6 years, so it's a little surreal to me that it's actually happening right now. I have many people to thank and acknowledge, but I'm going to save that for my closing remarks today because that may seem like the longest Oscar speech ever heard, and they may need to play me off with music. I wanted to kick off things today by sharing a summary of the access to augmentation journey that our organization has been on in recent years. When I joined Alpha-1 Canada in 2016, I had no idea I was entering a space with the most passionate patient community, committed researchers and physicians, and a rare disease space that was dismissed by our Canadian public payers, and many of our private health care insurance providers as well. So, within my first year, I was told by health ministry leaders, insurers, regulatory agencies, and even countless physicians, that my goal of getting equitable access to augmentation therapy for all Canadian Alpha-1 patients that required it was futile. I was new to the Alpha-1 space in 2016, but with a background in the organ and tissue donation system, I was confused as to why a plasma-derived therapy was not listed with the Canadian blood operators as other plasma therapies were. When I started working with Alpha-1 Canada, prescribed augmentation therapy was covered in the provinces of Quebec, Alberta, and British Columbia. That said, both Alberta and Quebec's coverage still required a rigorous special access review that could take many months to be adjudicated, and Alberta's special access program was actually suspended in 2019. In Ontario, for example, where over a third of our patients were based, there was no provincial coverage for augmentation therapy. And those who were fortunate enough to have private insurance and comprehensive workplace benefits often had lifetime caps on their insurance programs, or their benefits were discontinued at age 65. I didn't know when I took on my role with Alpha-1 Canada that a considerable amount of time would be spent helping patients relocate to British Columbia and Quebec in order to access treatment. A significant number of patients currently in BC relocated solely to access treatment, and I can see that many of them are online watching today. It is a tremendous amount of work, energy, and expense to relocate to BC. However, we have worked with dozens of families that have had to leave their jobs, families, and communities behind because it was the only way that they could access treatment. As you heard in our opening video, our friend Jackie was one of those many patients who made that difficult choice to move. Jackie, thank you so much for sharing your story, and thank you so much for being here today. I know many of your fellow Alpha-1 patients who also made that difficult decision. Sincerely, thank you for going public with your story. That said, there are literally hundreds of patients that we know that were unable to make that kind of a move. Sadly, many of them have been getting increasingly ill in recent years and have died prematurely. This is what we refer to as the postal code lottery, the disparities in healthcare between different geographic areas. But the question remained, why was augmentation therapy caught up in the postal code lottery when it is a plasma protein product? Canadian Blood Services had been providing universal and equitable access to plasma protein products at no cost to patients for nearly 2 decades. From a medical, biological, and biopharmaceutical perspective, there is no rational difference between augmentation therapy and the other plasma-derived products that Canadian Blood Services distributes. There was no technical reason why augmentation should not have been classified in the exact same manner as all the other listed products by Canadian Blood Services. When I began meeting with the individual health ministries in all the provinces and territories over 6 years ago to inquire why a plasma-derived therapy was not included with the other blood products with the national blood operator, I was met with utter confusion because governments could not understand why I wanted to discuss listing a treatment in the blood system for COPD and emphysema. Governments were already under the assumption that all rare disease treatments cost their provinces an excessive amount of money. Therefore, they were immediately dismissive of a treatment that costs upwards of $120,000 per patient per year for what they viewed as a treatment for a smoker's disease, COPD. And why on earth would I be asking to list a treatment for COPD with the blood operator? In fairness, there are over 7,000 rare diseases, so it is impossible for government decision makers to have extensive knowledge about any one of them, but it became glaringly obvious to me that we could not simply continue to repeat the same narrative about genetic COPD. We had to reframe it. Yes, alpha-1 is an inherited disorder that may cause lung disease and liver disease, but what conclusion did governments come to when they learned that? Lifestyle choices. Smoking, drinking. They were not hearing inherited, genetic. Therefore, between 2017 and 2020, I worked with each provincial and territorial health ministry to reframe the narrative. Alpha-1 is a hereditary disorder characterized by low levels of protein called alpha-1 antitrypsin, which is found in the blood. Reframing why alpha-1 patients need augmentation therapy because of limited to absent alpha-1 protein in their blood system was the beginning of getting decision makers to understand the disease and the value of providing replacement therapy, which they understood due to the missing protein in an alpha-1 patient's blood system. Finally, we had governments understanding the patient need and why treatment needed to be considered for the Canadian Blood Services plasma formulary, which we knew would be the only way to ensure equitable access to treatment for all Canadian alpha-1 patients. After many years of advocating and working with provincial and territorial governments, we were still told, quote, the level of available evidence and lack of cost-effectiveness data on products available in Canada creates a challenge with respect to implications for policy decision-making, end quote. Cost-effective patient care is a priority in the Canadian healthcare system. But we argued that Canadian Blood Services has proved that the needs of patients requiring plasma-derived therapies can be met while also negotiating cost-effective access to these therapies. Alpha-1 Canada spent years working with provincial and territorial governments, and we were proud to receive formal endorsements supporting augmentation therapy being added as a category on the CBS formulary by many other national organizations, of which I know many of their members are tuned in today. So bear with me. I would like to thank the Plasma Protein Therapeutics Association, the Family Physicians Airways Group of Canada, Alpha-1 Canadian Registry, the Canadian Lung Association, AlphaNet Canada, Canadian Network for Respiratory Care, Canadian Association of Genetic Counselors, Canadian Society of Respiratory Therapists, Canadian Vascular Access Association, the Network of Rare Blood Disorder Organizations, as well as the Canadian Thoracic Society, which develops evidence-based clinical practice guidelines to ensure the highest standard of care for patients. Finally, after 5 years of working with industry, governments, and CADTH, the Canadian Agency for Drugs and Technologies in Health, in September 2022, Canadian Blood Services recommended to governments that CBS undertake an RFP process allowing vendors to submit Health Canada-approved A1PI products with the objective of promoting competition among vendors and listing an A1PI product if a reasonable price is achieved. This was a significant milestone. However, we knew unless it was approved by the Conference of Deputy Ministers, this would be the end of the road. Needless to say, we had our work cut out for us that fall. After 3 months of intense government engagement, I received notice on December 23rd, 2022, that governments had authorized Canadian Blood Services to move forward with an RFP in the new year. I'm not going to steal any of Dr. Grenier's thunder here, because he will speak to the complexity of issuing and running a Canadian Blood Services PPRP RFP. But I will say that between February and May 2023, Dr. Grenier and his team worked diligently to have the final recommendation done in the spring. The final recommendation that came out of the RFP was submitted to government at the end of May 2023. 5 months later, I received the call that I knew we had all been waiting for, that the category had been approved and it would be Glacia that would be listed with Canadian Blood Services in early 2024. Before I go on, I do not want to forget about our Alpha-1 patient community in Quebec, and would like you to know that during the last 6 years, while working towards getting access through Canadian Blood Services, I was simultaneously soliciting the Quebec government to list augmentation therapy with their own blood operator, Héma-Québec. Though there is a provincial special access pathway in the province of Quebec, it is challenging to get timely approvals. Alpha-1 Canada requested transitioning access to augmentation therapy from the provincial formulary to their blood operator. We were informed in February 2023 that a transition was finally approved and that Héma-Québec would also be conducting an RFP with the intention to list augmentation therapy on the Héma-Québec formulary in 2024. We will certainly provide updates to the Alpha-1 patient community in Quebec as more information becomes available. In the meantime, current product and access to treatment in Quebec will not be affected and will continue to be available through RAMQ. To say the last 6 years have been an emotional roller coaster would be a bit of an understatement, but at every twist and turn, the patient community always showed up and participated in the countless activities that I needed to support our work. Patient surveys, patient and family interviews, focus groups, petitions, online letter writing campaigns, and patient video testimonials, none of which could have been done without our corporate sponsors, to whom I would like to express my sincerest gratitude. Educating decision makers by illustrating for them the comparisons to other genetic blood disorders took a lot of time, but we finally got there. This is where advocacy and reframing the disease and the patient need truly worked. By reframing the narrative, we were able to persuade governments to reconsider evaluating the treatment to be included in the nation's blood system. I would be remiss if I didn't thank Dr. Ken Chapman, who has indulged me for years, joined me in countless bureaucratic meetings, supporting me every step of the way. Dr. Chapman epitomizes what a physician champion is and the impact a physician champion can make. Thank you. Before I introduce Dr. Grenier to further expand on the Canadian Blood Services plasma, protein, and related products formulary, we're going to play a short video just to give everyone an idea about plasma, protein, and related products.
Plasma flows through your veins. It carries all blood cells, red, white, and platelets, around your body. It's on an important mission. Plasma is rich in proteins that protect your body from illness, infection, and excessive bleeding. These proteins can be used to make medications called plasma protein products. Not all products contain proteins that come from humans. There are other related products that are made with proteins and molecules designed in a lab as an exact replacement or to do the same job human protein normally would. So how does protein in your body get into a vial like this? It's a multi-step process that takes 9 months or more, starting from when plasma is donated. Canadian Blood Services collects plasma from both blood and plasma donors. All donations are blood typed and tested for infectious agents like HIV and hepatitis C. Safe plasma is shipped to manufacturers in the US and Europe. At the manufacturer, plasma, often from more than 1,000 donors, is put in large holding tanks. It's treated to separate the proteins from the mixture of plasma. The individual proteins are then removed. These different proteins are the key ingredients for making different plasma protein products. The separated proteins are purified using light, heat, filtration, and chemical treatments over time that inactivate or remove viruses. Then they're retested, ensuring they meet the highest quality and safety standards. These added measures protect patients, making these products extraordinarily safe for those who use them. Finished products are packaged and shipped back to Canadian Blood Services for distribution to hospitals. On behalf of provincial and territorial health systems, we buy and supply plasma protein and related products to Canadian hospitals, except in Quebec, which has its own blood operator. Worldwide, more and more patients depend on these products, particularly immune globulin, to treat a growing number of conditions like immune disorders, neurological disorders, and hemophilia. For more information, visit us online.
Thank you. So next I'm going to introduce Dr. Sylvain Grenier. He is a pharmacist and the director of Canadian Blood Services Plasma, Protein, and Related Products Formulary Program. Dr. Grenier joined Canadian Blood Services in 2019, and I personally could not have been more pleased to have him lead the PPRP program. We have worked through numerous challenges in recent years. However, his expertise and laser focus to ensure there is end-to-end support from the initial request for proposals to establishing an implementation rollout and utilization management is extremely admirable. Please, let me introduce to you Dr. Sylvain Grenier.
How much time do I have? Okay, thank you. Thank you, Angela, for this. As Angela mentioned, I think that's key to repeat that. As a background, I'm a pharmacist. And the presentation today, it's going to be more general about how CBS works. So not specific to Alpha-1, because I do realize it's a new community that we are interfacing with. So it's a way to really introduce ourselves. And then the second part of the presentation will get more into the specific of Alpha-1. This is also why we had the video to start with. The video that we presented there, and it's available on our website if you're curious to see and listen to it again. What's important is Alpha-1 antitrypsin is a protein that circulates freely in the plasma. Whether it's called prolastin, made by one company, whether it's called Glacia, made by another company, is the same protein coming from plasma as well. Okay, so I just wanted to reiterate that they're not synthetic product created in a lab. They collect plasma from thousands of donors and extract that specific protein to be used for that. It is the same process that is used to collect immunoglobulin or other type of proteins that are in the system as well. Before joining CBS, and again, I think this is relevant here for you to understand what the journey of the formulary management modernization was at CBS. Before joining CBS, I was in the military for 28 years as a military pharmacist. And the last 7 years, I was a chief pharmacist of the Canadian Armed Forces. And because of that, one of my roles was to be responsible for the drug plan of the Canadian Armed Forces. This is why a lot of the process that we've changed at CBS on how we manage PPRP aligns much more with the drug plans. And I believe this is one of the key success why way back before I joined CBS, we had received clear direction from the ministries that CBS would not be reviewing Alpha-1 product. And 5 years later, we have a product coming on our formulary. So in terms of disclosure, I'm a full-time employee of CBS, no other conflict of interest to declare. So all formularies in Canada would have similar pillars. Ours at Canadian Blood Services is really based on evidence. So if you look at the key mission there is to have an evidence-based formulary that will meet the need of the patient, but is also sustainable. On one hand, we have patient needs. On the other hand, we have funders that keep seeing an increase in the budget on all those products. And it's to find the happy medium where we can have the products that the patient needs at the best price possible for the provinces who are paying for those products. Obviously, safety is key. It's the fibers of Canadian Blood Services. Canadian Blood Services was created 25 years ago. For those of you who did not follow or maybe have followed it, it was based on the tainted blood scandal. A lot have changed since then, and the safety is still the key part of everything we do. Now, in terms of what we do is, Canadian Blood Services, we really have a systems-wide approach. We do from everything from collection of the plasma, having contracts for the fractionation. Fractionation is the extraction of the protein. The little video you saw, that's called fractionation. Canadian Blood Services does not do fractionation. To do that, it's significant investment that needs to be done, and we do that through commercial partners. So our plasma right now is fractionated by 2 different companies, Grifols and CSL. Those contracts change over time. And what we don't get from our own plasma, because we don't collect enough plasma to meet the need of all the patients that we have, the rest, we don't buy the plasma, we buy the final product. In the case of alpha-1, this is the example. We're not fractionating alpha-1 from our own plasma. We will be buying final product that will be coming from Takeda, which is Glacia. There's a product selection process. This is where I'm going to focus the most today. That's going to explain the journey of how we got Glacia approved on the formulary. Special authorization, I'll mention quickly. The whole point with this is when we do the product selection process, we determine products to be on the formulary that will meet the need of the patients. We are doing what we call population-based decision making, which means we know that not every patient is the same, but we are aiming at getting products that will meet the needs of most patients. So what do we do with those patients that fall in the cracks at the end? Well, we have a special process to make sure that the need of those specific patients are met as well. So we have process to be able to allow use of specific patient for specific products to specific patients as well. And the whole thing about utilization management, our goal at CBS, one of our role is to make sure that the products that we are buying on behalf of the provinces are used optimally. So it's not a question of reducing the use, it's making sure that the patient are using what they need to use to get the best results. So the first slide about the product selection process, the main question is the big red box at the top there. If there's a new product coming in, does it fall within the scope of Canadian Blood Services, or is it considered to be a drug? This is the part that Angela was talking about of alpha-1 antitrypsin being a plasma protein and should be coming through the CBS formulary. Now, in the case of alpha-1, there's a lot of history with that. Prolastin was introduced in Canada over 30 years ago. That was prior to the creation of CBS, prior to the creation of CADET, and it was introduced at the time as a drug. More provinces did cover it at the time, and then over the years, it did claw back. But there was always on the CBS view in statements that alpha-1 was a plasma protein and is a plasma protein, and if carried, should be carried on the CBS formulary and not the drug plan. So that's the first box. It took many years to convince the PTs about that. Once we got that approval, that was prior to the initial review, which was started with Zemira. Some of you may have followed that as well. That did not guarantee listing, but what it guaranteed is if the review was positive, the listing would happen through CBS. Okay. Now, if the answer would have been no, then it would have gone on the blue boxes. I'm not going to cover those. It's what drugs, the drug pathway happens in Canada. So CADET does a review, and then negotiation happens, and each province and territory determines if they want to list it or not. This is what you see right now with Prolastin. BC pays it, others pay it with criteria, others don't pay it at all. That's the typical thing. If we focus on the right-hand side, sorry. Once it comes to CBS, there's 2 pathways to be done. If it's a novel therapy, if it's a drug, a product that we never carried on our formulary, which is the case for alpha-1, that would go through the assessment with CADET. This is what happened when we did the review with Zemira. CSL approached us, we reviewed it, CADET did the initial review, and I'll get in more detail on what is actually done by CADET. They issued a recommendation. That recommendation was, yes, there's evidence that alpha-1 is working for the patient population, but the price that was submitted through the Zemira review, which was specific to that brand, required a significant price reduction. They were quoting 93% price reduction to make it cost effective. Now, alpha-1 was a little bit unique because alpha-1 was not a new product. Alpha-1 was covered as a drug, which was done in a point in time, and that needed to be corrected. Where we saw an advantage was that we had the opportunity of conducting an RFP and have multiple products reviewed against each other to be able to get better pricing, and I'll get back to that a bit later. The left-hand side is the RFP process. Most of the products that we have on our formularies are plasma proteins, and because they are, like I explained earlier, the same proteins coming from the plasma, conducting an RFP, a request for proposal, allow us to have the best price possible for these products in Canada. So on a regular basis, 3 to 5 years, we conduct RFPs to look at the patient and the population needs to see if they've changed, and then to look at what products are available in the market, and then we conduct that RFP to determine what the formulary will look like. So we've conducted an RFP in 2020 for recombinant products. We conducted one in 2021 for plasma-derived product. And then, of course, we did the one for alpha-1. The next time alpha-1 will be reviewed in an RFP will be the next time we will do a plasma-derived RFP 3 to 5 years down the road. What does it mean at that point? Well, at that point, unless there's new evidence coming in that one of the product would be superior to the other. Right now, there's no evidence of that. In fact, there's evidence that one of the products at least is non-inferior than the other ones. Well, at the outcome of the next RFP, it could be a different brand that will be added to the formulary. So that involves having transition that is happening more often on the plasma-derived product than happens on the drug side. This is common. We do that often with immunoglobulin coagulation factors, and we've become quite expert on managing those type of transitions. Now, if I get into that process that is with CADIT, how products are reviewed, CADIT, with our help, will help identify who the clinicians are that work in that field, and who the patient groups should be involved, then we provide the feedback. But the rest of it is redone by CADIT. CADIT does the medical scientific review. CADIT does a pharmacoeconomic review of the product. They do the patient consultation, and then using an expert committee, they issue a recommendation. They are not a decision-making body. They are issuing a recommendation. Now, out of that recommendation, Canadian Blood Services takes that recommendation, and we reach out again to clinicians, patients, other committees like the National Advisory Committee on Blood and Blood Product to get an impact assessment about the recommendation that was issued. We're not asking people to see if they're happy or not with the recommendation. We want to know if that recommendation is listed as is, what will be the impact? Are there criteria that don't make sense? If it's asking for a specific lab test, does that lab test is available throughout Canada? Because we've seen that in other products where a specific lab test was being required, wasn't available in several provinces. So that's the type of impact assessment that we're asking. We are then entering into negotiations with the company to try to reach the best price possible. And then out of that, we do a budget impact assessment, which we send to the provinces and territories for them to make a decision. At that point, CBS again issue only a recommendation. We are not the decision-making body. We're not the one paying for the product. The provinces are. And then the CDM, the Conference of Deputy Minister, does issue that recommendation. One major difference on the CBS formulary versus the drug plan is when the provinces meet together to have that discussion and decision, when they come back to CBS, they come back with a single decision for everyone. So it's not one province says yes, the other one says no. When they come to us, it's either yes for everyone with the same criteria for everyone, or no for everyone. So it's really a national system. Obviously, I exclude Quebec because Quebec has EMA Quebec in their piece there. Here it just compares again what happens on the CBS side, which is on the red side, versus on the drug side, which is the green one. So Prolastin would have followed more of a, well, it was years ago, so some of the steps they've been skipped, but that would be more on the right-hand side. So the first part, who conducts the product review? In the case of plasma-derived product, it's CADET with the help of CBS. Who negotiate the price? As I mentioned, in our case, it's CBS, whereas on the drug side, it's an organization called PCPA, Pan-Canadian Pharmaceutical Association. Who engage with the stakeholders? Again, we're doing it CBS on behalf of all the provinces, whereas on the drug side, each drug plans would be consulting with their own patient groups. Who makes the decision to list? This is the key point. Conference of Deputy Minister for us. So the Deputy Minister of Health of every province are part of that Conference of Deputy Minister, and they are the ones making the decision. And it's a unique decision for the country. Whereas on the drug side, as you very well know, each PT has their own decision making. Who distribute the product? In the case of plasma-derived product, all of those products are distributed through CBS. So we have a vast network of hospitals, distribution sites that distribute blood and blood products. So this is how products are being done. Whereas on the drug side, it's normally private distributors that would be doing that. And then who manages the formulary? In our case, it's CBS. So my team at Canadian Blood Services manages the formulary. We do the review, we do the utilization, all of this. Whereas on the drug side, well, it's the drug plans doing that. I should have added one more box. How do product gets to the patient? In the case of Canadian Blood Services, the products get to the patient using the blood banks. So we distribute to the hospital, we distribute to the blood banks, and the patients are able to get their products from the blood banks. There's no cost involved with that. There's no dispensing fee from the patient. There's no requirement for insurance. There's nothing that has to do financially there. It's just everything is paid up front by the provinces, and that's the end of it. Now, we do have a project in Alberta that I have to mention because that environment might be changing over the years. We have a pilot in Alberta where we are trialing to distribute our products through specialty pharmacies. The one that we've picked as, again, we conducted an RFP, we picked a partner, the one is Bayshore Pharmacy. And what Bayshore Pharmacy will be doing in the pilot in Alberta, it's for one drug called emicizumab, it's for hemophilia. It's only for the pilot. And in that case, Bayshore will be sending the product directly to the patient home. So the patients won't have to go to the blood bank for that. Now, what I can share with you as well today, the Alberta Ministry we've been in discussion with them to see if they would consider the possibility of including Glacia in that pilot as well. And the government is open for us to investigate more. So at this time, it's too early to say if in Alberta it's going to go that way, but there's a possibility for Alberta that Glacia will be distributed through that specialty pharmacy rather than the blood banks. The other provinces, unless we get direction from the provinces, at the moment it will still be going through the blood bank. Final thing about Bayshore, if it goes through Bayshore, although that pilot changes how the product is distributed, the funding model does not change. It's not because it's a pharmacy that people have to have insurance, that there's dispensing fee. All of that is covered by the provinces again. So the only thing is, instead of having to go to the blood bank to get the product, the patient gets the product at home by Bayshore Pharmacy. So the RFP, I'll get a little bit more in detail on how it happens. So we do that every 3 to 5 years. We've just done one for Alpha-1 for Glacia. It's going to be added as part of the plasma-derived RFP in the future. When we conduct a typical RFP, it could take in the range of 12 to 18 months to conduct. It is a very thorough process. Before we start the actual posting of the requirements, we meet with the patient groups, with the clinician groups to identify the needs, to see if there's no new needs that have happened, and to establish what will be the criteria that we will evaluate the product against. So it is an extensive consultation that we do prior to it. When the RFP actually starts, the stakeholders, so patient groups, clinician groups, are also involved as part of the evaluation committee to score all of the products. So it's not something that CBS does in isolation. There's involvement in the patient community. Those people representing the patients and the clinicians still have to sign the non-disclosure agreement because they're reviewing all confidential information. We are evaluating all the products from the different categories within each category against each other. And then the overall goal of the RFP is obviously to get better pricing as possible, but it's to meet the need of the patient as well. So we're not going to list a product that is cheaper if it's not as effective as another product. This is why we have a list of criteria on why products are important or not. So for example, criteria could involve things like shelf life. Does it need to be refrigerated or not? If there's two products in the same category, one that requires refrigeration, the other one not, well, that one will get more points, for example. Does it come in a pre-filled syringe versus in a vial? Those are the type of things that will give points to a product versus another one. Now, a key point as well is the evaluation of the manufacturer of those products as well. There are not a lot of manufacturers that do produce plasma proteins. There's a handful of them. So when they apply for the RFP, we will evaluate the way they manufacture the product, how many fractionation plant that they have. So if one has a failure, can we have a backup elsewhere? And all of those factors will also be evaluated in there to ensure security of supply. Because we don't want to end up to award a contract to a company and all of a sudden they can no longer supply the product. Because like in Alpha 1, all the products that we carry on our formulary, for most patients, they are life-saving. So we can't play with those ones. So the result of that, it's a competitive competition happening between the vendors. So they're the ones really driving the price on between themselves. We do negotiate safety stock. So part of our contract, every manufacturer has a responsibility to carry a certain amount of weeks on hand in Canada. CBS, we also have our own inventory. So we have many months of supply in Canada available at any given time. I've mentioned that. Now, the review of the product is really a two-step process. So once we've established the criteria, the first thing is to rank the product based on the points they get over the price. So we rank the product, but we just don't look at this that way. We then look at what the product mix should look like and what will be the decision out of that. So for example, when we conducted the RFP for Alpha 1, the main goal we knew was to reduce the price because it was to get the provinces and territories to make a decision to list. So the main criteria, and we had reached out to the patient groups, to the clinician groups, to first get confirmation that there was no feeling that one product was superior to another one. There was no evidence of that anyways, and we got support on that. And that price was really what we were driving. So for that RFP, it was a little bit special. Most of the weight was on the pricing, not a typical RFP for us. But that also allowed us to do it in a much shorter time frame. We didn't take 18 months to run that RFP. We did only a few months to be able to conduct that. And the result of it got us the cheapest product from the, and don't see cheap in terms of quality of product, see cheap in terms of price, right? And that really what was able to allow us to get listing by the provinces and territories. But in a typical RFP, we don't look just as that. We look at the product mix. Do we need more than one product? In a situation like immunoglobulins, there is a global shortage of immunoglobulins. So we would be pretty irresponsible if we only went with one manufacturer and that manufacturer has a problem and we can't get any more immunoglobulin. So that's a decision-making point as well for us to determine what needs to be there. So the next RFP for Alpha 1, will it mean only one product? Will it be more than one? I don't know that. We'll know that when we conduct the RFP. It's going to depend on the volume of Alpha 1 product we get, the security of supply of that product, and all of the things that are happening. At the end of the day, CBS, where we add value to the provinces and territories, is the national buying power. When we negotiate on behalf of all the provinces, and the result comes as all in or all out, it does give quite a bit of power to Canadian Blood Services to reduce the pricing for the various companies. We bring equitable access. It's been mentioned several times this morning by Angela. Once it's on our formulary, the same access happens everywhere in terms of criteria, so there's no differences between criteria. In terms of timeline, when we will be introducing Glacia, the introduction will be happening everywhere at once. It's not going to be one province and then 6 months later another province and then maybe 2 years later another province. It's all going to be happening at once. And in CBS, it's also part of our fibers to make sure that patient needs are being met. So we have an extensive stakeholder engagement. The definition of stakeholders for Canadian Blood Services is really focusing on patients and clinicians. So we have a very strong stakeholder engagement. Angela has been experienced already with doing this. Me personally, I go to several patient conferences for different diseases to talk about inventory issues, review process, and things like that. So it's the first time you meet me, but it's hopefully not the last time that you'll be seeing me. So that's the general piece about Canadian Blood Services. Now I'll get more into the pieces that is more specific to Alpha-1. This is why we had the call today. And again, I'd like to congratulate Angela to have the idea of having that forum. We know that we don't have all the answers today. We've just got the decision a few weeks ago on the approval from the province and territory to list Glacia. So we don't have all the answers. But what we're here to do today is to share with you as much as possible on what we know, and what we don't know, then we will be working on that. Now, as I mentioned, Canadian Blood Services is quite used to do patient transition. The vendors, Takeda in this case, quite used to do patient transition because every 3 to 5 years we have to do that for several patients. In this case, we have one added layer of complexity. Prolastin is not something that is carried by CBS. It's provided by the drug plans. The good thing is we have a good relationship with the provinces and territories, so we can have also a direct link with their drug plans. In the case of BC, we've already been told that their top priority is to make sure that patients will not lose access to product. So it's not that they're going to come at a date and say, well, we don't provide Prolastin anymore, and then too bad if the patients don't have Glacia. So they've confirmed with us that we will be working with them, we will introduce Glacia, and when there's no more need for Prolastin, it's going to be removed. Typical transition, when we control all ends of it, takes between 6 to 12 months. So it's not something that happens overnight. In the case of Alpha-1, we will have to see. I know there is a lot of challenges getting appointments with the specialists to get prescriptions. Several patients on Alpha-1 don't even have access to Alpha-1, so it may even be longer for them. So we will take that into consideration. And because of that added complexity, what we've done is we've made a decision that we will have an implementation team that will go beyond just CBS. So we will have representation of the patient group, representation of the clinician, the manufacturer will be there, CBS will be there, and then we will meet on a regular basis to have questions and answers so we can see how it's going, and also to help with the communication as well. So I think I'll leave it at this for now, and I don't know, we'll have a panel later for the questions. Perfect. Thank you very much, everyone.
Thank you, Dr. Grenier. He will be back when we open up for our panel discussion in a little while to answer any questions. I do see questions slowly coming in. If anyone online would like to submit, before we open up to the Q&A, it's info@alpha1canada.ca. I am monitoring the questions now. So next, I'm excited to introduce Dr. Jefferson T., Vice President of Medical and Scientific Affairs and Head of Patient Support Programs for Takeda Canada. He leads a team of professionals in medical affairs, research and development, patient services, regulatory affairs, and quality operation. Dr. T has been with Takeda for over 10 years and has over 25 years of experience in the biopharmaceutical industry in research and development, medical affairs, marketing and sales, patient services, and market access. Please join me in extending a warm welcome to Dr. Jefferson T.
Well, thank you, Angela, and the Alpha One community for this event, and heartfelt thank you for Angela for all her perseverances over the last years for this moment to happen today. So as Angela had mentioned, my name is Jefferson T. I head up the Medical and Scientific Affairs function within Takeda Pharmaceuticals. It's a company that I joined about 15 years ago, and part of my role is also to interact with Health Canada, which is something that I have done for the last 5 years behind the scene. It has been a lot of work behind the scene with Dr. Chapman, also part of all those discussions that kind of led to the Health Canada approval of Glacia. But today, as Takeda may be new to most of you in the Alpha One community, I'd like to take the opportunity just to introduce who we are, what we do, and more importantly, what you should expect from Takeda as we move forward with this journey over the next few years. So certainly this event, it's an important event for sharing information, but also to really share our commitment, not only in the short run, but also in the long run with the Alpha One community. So Glacia is one of the product that, as CBS had mentioned, has been approved. But we're fully committed to the Alpha One community with several other research programs that is in the pipeline. You may have heard in the public space that we have shared very positive phase 2 clinical trial results with another of Alpha One, a small molecule targeting the reduction of fibrosis in the Alpha One induced liver disease patients. So certainly my main message here is that we're not just here for the next 3 to 5 years, but we're really here for the long run. So from a Takeda standpoint, plasma-derived therapies is not something new. We've been distributing plasma-derived therapies over the last 75 years throughout the world, right? So currently we do have over 150 plasma collection sites, predominantly in the US, but we're also expanding our network in Europe. In the case of Glacia, it will be manufactured from Belgium, and the great news is that just about a week ago, we started really a production chain for the lot that will be distributed here in Canada. So the other news that I wanted to share is that you may have Googled, Glacia, probably in the internet, and you may realize that Takeda has been distributing Glacia in the US for the last 10 years. So this is not something new for us. We're very confident. We do have the experience with our neighbors down south. And it's been over 10 years that we've been doing that. So we can certainly learn a lot in terms of implementing, all the best practices to make sure that that transition to all the patients here in Canada is really seamless. Takeda has been around for a very long time. We've been around for the last 240 years. It's a Japanese biopharmaceutical company, and we are present in over 80 countries. We are predominantly focusing on 6 therapeutic areas, bringing new medicines to our patients on a continuous basis. And these 6 areas are gastroenterology, neuroscience, oncology, plasma-derived therapies, as we have discussed, vaccine, and a special focus on rare disease. Actually, when you look at our pipeline, in terms of research and development, 60% or more of our efforts and of our early molecules are targeting rare diseases. So this is something that we're fully committed in the long run. Our values from Takeda's standpoint, it's really centered around the patients. We often, welcome new employees within the company by sharing our values that is centered around what we call the PTRB. So P standing for the patients, T for trust, R for reputation, and B for business, in that order. What it means is that on a daily basis, and this has been the exercise that we came throughout the RFP, is really to ask the question first and foremost, what is the most important thing to do for patients? And second and third, it's really to ask the question, what will be that impact in terms of trust and reputation to the community? And if we do that very well in that order, we strongly believe that business will just follow. And this has been our mantra for the last 240 years. And patients will remain the core of what we do. With regards to the Alpha One community, as I have mentioned, this is something that we've been focusing for many years because we're there for the long run with the number of investment that we have in our pipeline. And we understand that there's a huge unmet need with the Alpha One antitrypsin deficiency patients here in the Canadian space. And prescribing a drug to these patients, it's only the beginning. We've heard that this journey might be long, it might be very difficult over the last few years. It has been very challenging. But we, keeping that in mind, at Takeda, for all our molecules, we have, and medicines, we have patient support programs. So the patient support program at Takeda is called One Path, and you'll be hearing more and more around our program to support all the patients across the country. And this is really to provide support, resources, and all what patients need at no cost. Currently, we have 11 programs running across the country, serving over 20,000 patients on a year-to-year basis. And we do have a partner that is called Innomar, that you may be familiar with, that we've been partnering for the last 10 years. And we're very confident with that partnership that is going to provide tremendous value, tremendous positive experience to the patients. Certainly, we want simplicity for the patients. The moment that you receive that prescription, we don't want you to think anything else than receiving the medicine to treat your condition. All the rest will be taken care of by the One Path program. So we wanted to make this as simple as possible. So you may ask the question, how does that work in reality? So I can talk from experience with all the other programs that we have. So typically, once a prescription is written by the physician, an enrollment it's completed and then sent to the One Path patient support program. From there, within 24 hours, we do have specialized One Path care managers that will contact the patients within the next 24 hours guaranteed to really talk about the program, to ask questions with regards to the needs of the patients so that we provide really a program that is personalized to the needs of the patients. So this is really an end-to-end offering that we're providing to patients. And the One Path care manager is fully trained on both the product, but also the disease state, and also on all the patient journey with regards to the Alpha-1 antitrypsin deficiency patients. Some of the other things, and this is not an exhaustive list of the things that the program will do, is that scheduling will be an important component, whether it's to schedule the patients to pick up their drug from the blood bank, and we will be working very closely with CBS, or scheduling the patients to their next infusion clinic visit. Innomar has an extensive infusion clinics across the country. They have over 160 infusion clinics that the patients can choose from. Obviously, for the current patients that are on prolastin, this won't change anything because they're already receiving their infusion at the Innomar clinic. So they'll continue the same way. For the new patients on Glacia, obviously the choice is for the patients. They can choose to go to any of these 160 plus infusion clinics that is available to them. So this partnership that we have created with Innomar has really bring value to patients across the country. The other thing that I would mention based on our experience in the US is that we'll be also offering value-added services based on the needs of patients. One of the value-added services might be self-infusion. So if deemed appropriate for the patients and for the healthcare providers, self-infusion can happen at the home of patients. So for that to happen, the patient support program, One Path, will provide a nurse, an experienced nurse, to fully train the patients how to infuse, whether it's in a clinic setting or at their home. So we'll be sending those experienced nurses to train the patients until they get really comfortable and independent to infuse themselves the medication. And again, all of this at no cost. We can even send the supplies related to the self-infusion to the homes of patients. So again, our intent is really to make it as simple as possible. So with regards to Glacia, as Sylvain from CBS had mentioned, there is a change in terms of the process. You have heard that in this case, because we're selling Glacia to CBS, CBS is actually the distributor of Glacia. So therefore, as obviously things may evolve in the future, what you have heard is that patients will have to pick up their medicine at one of the blood banks. So this model may evolve into the future, as we had just heard from Sylvain and the pilot program here in Alberta. We fully understand that this might be a change. We fully acknowledge that. Regardless of how that model will evolve into the future, we'll follow, the needs from a CBS perspective in terms of following due processes, but also meeting the needs of our patients. So just rest reassured, as Sylvain had mentioned, we're going to be working very closely when it comes to implementing the detailed processes that's going to happen when we're going to launch the drug in a few months. And we'll be working very closely with CBS, with healthcare professionals, obviously Dr. Chapman, and as well as patient groups such as Alpha One Canada. So this is what I wanted to communicate to the audience today. Again, you have our commitment, not only in the short run, but also in the long run. And hopefully, you have a glimpse of what Takeda is doing and has been doing for the last little while. So on that note, I'd like to close by saying thank you. Thank you for being here today. Thank you for the Alpha One Canada organization for organizing such a very informative meeting for all of us. Thank you very much.
Thank you, Dr. T. I'm not sure if people can hear that, but the stage is a little squeaky. So as I introduce our next presenter, it is my distinct pleasure to introduce Dr. Mohit Bhutani. Dr. Bhutani is currently president of the Canadian Thoracic Society, the National Interdisciplinary Specialty Society for Respirology. He was elected to the Canadian Thoracic Society executive in June 2020 and serves as the current past chair of the CTS COPD Clinical Assembly and a past chair of the Scientific Planning Committee for the Canadian Respiratory Conference. I'm going to say a lot of acronyms today. He is the director of the University of Health Asthma and COPD Clinics and a member of the executive of the Alberta Research Centre. Please help me in a warm welcome for Dr. Bhutani to provide some or offer some greetings from Canadian Thoracic Society. Thanks.
Should be cool. Okay, no problem. I'll try to stand still. Good morning, everyone, and good afternoon to those who are joining us online across the country. Thank you, Angela, for the invitation on behalf of the Canadian Thoracic Society to be here today on this very exciting day and journey that you've had to help change the lives of patients living with alpha-1 antitrypsin. So, Angela asked me to talk a little bit about our organization, our society, and I'll do that, but also I want to just share with you how we've been partners with the alpha-1 community over the decades. So, first of all, just our vision and mission statement for the Canadian Thoracic Society. The vision is to improve the lung health for all Canadians, and then the mission is to promote lung health by enhancing the ability of healthcare professionals through leadership, collaboration, research, learning, and advocacy, and providing the best respiratory practices in Canada. So who are we? We are, as Angela mentioned, the National Interdisciplinary Medical Specialty Society for Respirology. What's unique to us is that it's not just a physician-based organization. We have a collaboration with the Canadian respiratory health professionals. And so occupational therapy, physiotherapy, respiratory therapy, they are partners with us in our society. We are 820 members strong at the moment as of August of 2023, and we're continuing to grow. We are the medical and scientific authority for respirology in Canada, and we do write the clinical practice guidelines for a number of different respiratory conditions, including alpha-1 antitrypsin deficiency. And so we do set the standards, and we set the criterions, and we look at the evidence to help us provide the best and optimal care for patients living with a number of respiratory diseases. We are also an educational body, so we are an accrediting body of the Royal College of Physicians and Surgeons of Canada. We just actually recently renewed our accrediting privileges with the Royal College, and for the next 8 years, we do provide the reviews and the processes to provide the best education to our healthcare practitioners. I'm currently the 66th president of the Canadian Thoracic Society, but we were an arm of the Canadian Lung Association for many years. And in 2015, we became a separate organization, and we have our own group of executive directors and board of directors as well. So this is the current executive. So I'm the current president. The president-elect is Dr. Melinda Solomon, who's a pediatric respirologist at the Sick Kids in Toronto. Past president is Dr. Richard Lee from Calgary. And then when you get elected to the executive, it's a 6-year commitment. You start off as secretary. So Véronique Pepin, who is a PhD physiotherapist from Quebec, she is the newest member to the executive. In 5 years, she will be president. And this just gives you a sense of the fact that we have this relationship with the Canadian respiratory health practitioners. They are involved in our leadership as well. And so every few years, we incorporate them into the executive and leadership positions. And this is our board of directors. So it's a wide variety of folks from across the country with a number of different roles and responsibilities helping advance the mission of our society. So CTS and alpha-1, how has this relationship been built? Well, we've had a long-standing history in terms of evaluating the evidence of where alpha-1 antitrypsin should be used in clinical practice. The first guidance, and Dr. Chapman was involved with this, was published in 1992 in the CMAJ. And then over the years, we've had a number of different iterations of the guidelines regarding how alpha-1 antitrypsin should be incorporated into the care for patients with this deficiency. And so the one thing, so the last guidance was in 2012, and the current recommendations are based on this guidance. The one thing to remember is that the CTS, we have a very strict guideline methodology. So our Canadian Respiratory Guidelines Committee, the CRGC, they have a science and guideline development that helps us evaluate the medical evidence and helps us to provide the guidance in terms of how we want to implement treatments. So the science really informs the recommendations. Over the last several years, alongside Angela, we've helped Alpha-1 Canada and we've been part of the process here with Canadian Blood Services in terms of trying to evaluate the submission and provide an evaluation and provide a clinical context as it relates to alpha-1 antitrypsin. So this is just a slide giving you a sense of the guidelines we're currently working on. We've recently published a guidelines on the use of meter-dosed inhalers and climate change, and sort of trying to make sure that we have a societal global consciousness of how we treat patients in the most environmentally friendly manner. We've recently, just in September, published our updated COPD pharmacotherapy guidelines, the 2023 COPD guidelines, which I think are the most progressive guidelines available worldwide. And we are currently, relevant to this group, as we are working on an update to the alpha-1 antitrypsin deficiency guideline, and we're hoping to have that, well, we will have it out in spring, summer of next year. And then there's a number of other guidelines in severe asthma, in pediatric obstructive sleep apnea, and then we're looking at quality indicators for bronchoscopy, which is in the evaluation of the airways. What is unique and what's been really progressive is that our guidelines now will be published in 2 journals. So one it'll be published in the Canadian Respiratory Critical Care and Sleep Medicine Journals, which is our journal of the CTS. But we have an agreement with the American College of Chest Physicians to publish in the Chest Journal as well for all of our guidelines and position statements. And this is a really important evolution for us, because the scale and spread of our guidelines will be international. The Chest has a very large readership that's global. So when our new alpha-1 guidelines come into press, it's going to have a global reach, and we're very happy about this, because I think our guidelines are just one of the highest quality guidelines made, and I think our guidelines will have an impact on not just the Canadian alpha-1 antitrypsin deficiency patient, but the global group as well. So this is actually a very important development for us. We will, at the Canadian Respiratory Conference, so our national conference is called the CRC, Canadian Respiratory Conference, and so this year, or in 2024, it'll be in Toronto. Those are the dates, so if you're interested in attending it, we have already developed the program, and there will be a session on alpha-1 antitrypsin deficiency, including the updates of what's happening here today. So we're going to try to share and scale and spread it to our national audience through the CRC as well. So I would extend a welcome to everyone in the room and online to attend the conference if they're able to. So what are we going to do kind of going forward? And so one of the things we're going to do is through our e-bulletins, which come out every couple of weeks, we are going to inform all of our membership regarding this development that's going to change. And so with guidance from Alpha-1 Canada, CVS, we'll share all this information with our clinicians. So important to get the word out about the transitions, and any updates that need to be had, we'll do through our e-bulletins on a routine basis. We would welcome Takeda and Canadian Blood Services to use our educational platforms to educate our health practitioners. So I would just make that open ask today that please leverage us to help the scale and spread of informing the clinicians who are going to be writing the prescriptions for these medications, for this medication, to teach us how to do it in the most efficient manner so there's no delay. And then lastly, we'll partner with Alpha-1 Canada on the scale and spread of the guidelines. So in summary, we are very thrilled about this announcement. As a clinician, someone who has alpha-1 patients in my practice, this is a very important day. As Angela mentioned, the program has been suspended here in Alberta since 2019, and it's been very frustrating. This announcement, I think, is just phenomenal, and credit goes to you, Angela, and your vision and your hope. And you know, when we first approached this idea, we were like, wow, this is a big task, and my gosh, you accomplish it, which is amazing. And thanks to everyone here in this room and the Alpha-1 patients across this country who have helped support this journey, because you're not only changing lives the life for yourself, but for generations to come. And this is going to be a transformative change for everyone who will be diagnosed with this disease. So congratulations to all of you. So with that, I thank you for the time, and then I'll be up for the panel a little bit later on today. So thank you.
Thank you, Dr. Butani. I met Dr. Butani, 5-6 years ago at one of the Canadian Respiratory Conferences, and Dr. Chapman was there, and there was probably half a dozen physicians from the leadership team at Canadian Thoracic Society. And I was a little nervous to make my pitch for what I wanted everyone to do. I knew Ken would support me, but I didn't know about everyone else. And it was Dr. Butani who, I remember it like it was yesterday, said, absolutely, What do we have to do? Okay, just tell us, we'll do it. So thank you for that. I really appreciate that. Now, I have the pleasure and honor to introduce someone who's been a part of the access journey well before I joined the cause. Dr. Chapman is director of the Asthma and Airway Center of the University Health Network, a professor of medicine at the University of Toronto, and director of the Alpha-1 Canadian Registry. But he's so much more than that. For decades, he has been a lifeline for Canadian Alpha-1 patients, and it has been my honor to work with him in recent years. Please help me welcome Dr. Ken Chapman.
Well, thank you. I am excited to be here today. This is a day that I never thought would arrive. There's a feeling of unreality about it all. And I noticed on the agenda that other clever people were going to say all sorts of really useful things, and I wondered what I would say. And I think it may be important just to share the story. So in my own idiosyncratic way, I want to share the story. It's an important story, and I thought to myself, I have a problem here. I'm a doctor. Worse, I'm an academic doctor. So when I start talking about things medical, I start to drift into doctor speak. I'll talk about Hounsfield units and power calculations and p-values and lines of regression, and pretty soon the audience is asleep, and this story is just too important for that. So I've set aside the slides, the graphs, the p-values, and so on, and I'll tell you the story as I have seen it, not always personally, but as I've seen it evolve. The story begins in the 1950s and 60s. Two really diligent clinical biochemists, Laurel and Erickson, doing what was then state-of-the-art clinical measurements in Malmö, Sweden. They were doing some testing, serum protein electrophoresis for all of Sweden, and they would peer at their results. They would see these little bumps that indicated globulins were present in blood. And every once in a while, they would notice a bump that should have been there wasn't there. Many people would have looked at that and said, oh, there's some variability in our test results, some differences from person to person. But they were diligent, they were hardworking, they were clever people. And they went back to where these blood samples were taken and discovered they tended to come from pulmonary wards. The people who had donated the blood tended to have lung disease, emphysema, and the emphysema was a little different. It tended to occur early, maybe without much tobacco smoking having been involved, and if you looked closely, most of the emphysema was at the bottom of the lung, not at the top where tobacco usually produces its damage. And they published their results, and it became clear that they were talking about something genetic, something that was familial. And later on, we added some of the other bits and pieces, the liver disease, the skin problems, and so on. So that was the beginning of the story, and in some ways, what should follow is obvious, but it took a very long time. That was 60 years ago. These two fellows said, alpha-1 antitrypsin in very low levels is associated with emphysema. And so the next step should be, well, if we give some alpha-1 antitrypsin to make up the difference, if we augment, that should prevent problems. It took another 25 years for that to happen, but investigators at the NIH and at Qatar Labs developed purified alpha-1 antitrypsin. So I'm going to pause for a minute. Something very important there. A quarter of a century to test out that solution, augmentation therapy. Why so long? And I'm going to challenge people who are listening, particularly the patients. This is a rare disease. They're often called orphan diseases. Orphan because it's hard to do research when there aren't many patients with the problem. And in terms of investing in research, well, there aren't many people who need the treatment. Well, it's cold, hard facts. If you've got alpha-1, it takes a while to get this research done to produce great new treatments. So remember, that first huge step was a quarter century in the making. Later on, we're going to hear questions from people about their treatment and how it should be given and should it be given. And as those questions are asked, I'm going to challenge back and say, well, we'd have a lot more answers if everybody shared their information. There's a Canadian registry. It's morphing into a part of a large international registry. So if you're at home wondering what you can do to make sure it doesn't take another quarter of a century for the next step, please give some thought to registries. So in the late 1980s, augmentation therapy became available. It was prescribable in Canada. And pretty soon thereafter, the Canadian Thoracic Society weighed in, and Dr. Bhutani Mohit mentioned that I was part of that. Actually, not that first statement. And it was an interesting statement because it set things off in Canada in a strange new pathway. The first statement from the Canadian Thoracic Society said, this is all very interesting. We can see that blood levels can be improved with infusions once a week, and we know from the research that that alpha-1 antitrypsin protein appears in the lung when we lavage, when we wash out the lung. But what we don't know, we lung doctors, is whether our lung measurements are better maintained when people get these infusions. So we think there's need for more research. Hard to argue with that. More research is always a good idea. The problem is a lot of Canadian doctors, especially the lung doctors, thought, okay, well, this is something in the realm of research. Up till the present year, I still get referrals from Canadian pulmonary doctors thinking that the only access to augmentation therapy is through a research trial. They don't realize that this has been a prescribable therapy for 3 decades in Canada. I think our patients know this. They know that they run into doctors, even lung specialists, who know very little about alpha-1. Diagnoses are delayed. Treatment is not offered. How to get treatment is a mystery to the potential prescriber. And you've already heard the need for education to be flagged. We do have a platform for that, the Canadian Thoracic Society, so that's good to hear. And this is going to be the challenge for Canadian Blood Services, Takeda, Canadian Thoracic Society, and for patients, getting Canadian pulmonary doctors up to speed, because this enhanced access is going to change the landscape. And doctors who've never thought before about augmentation therapy for alpha-1 antitrypsin deficient patients are going to be challenged to consider it and perhaps to prescribe it. So, a lot of work for us all to be done. Some of what I want to say next has been said before. Let me try and say it in my own words. Angela has shared with me a little bit about the questions she's been getting, and I think one overriding question is, what is glassia? What is this stuff? And I think that's an obvious patient question, because patients have had a different experience before with the regular prescription drugs. If you have pills for your blood pressure, if you have an injectable for your diabetes, an inhaler for your asthma, you may have gone to the pharmacy one day and the pills are a different color. The inhaler looks different, the syringe is different, and the pharmacist says, yes, that's the generic replacement. And I have a feeling a lot of Canadian alpha patients who are aware of the term prolastin have wondered, well, what's this glassia stuff? Is it some knockoff generic? And you've already heard very clearly from Dr. T, no, it is not. Takeda has been in the blood product arena, I believe I heard as I was coming back in the door, 75 years. They currently supply, if I'm correct, immunoglobulin, or one of the suppliers of immunoglobulin, to Canadian Blood Services. They're one of several companies that carefully purify Mother Nature's alpha-1 antitrypsin. Glassia, Mother Nature's alpha-1 antitrypsin. Prolastin, the same. Arelast, various other products made by different companies, all to exacting standards, the same. And we heard Sylvan say that maybe in 3 to 5 years it'll be glassia again, but maybe it's going to be prolastin, maybe it's going to be somebody else. All of it is simply the same purified blood component. So what you're getting is exactly what the scientists said you should be getting. And these are all equivalent, although there might be slight differences in, for example, the formulation. And you've heard a liquid formulation, which glassia is available in, gives us an option. Some patients who live in the back of beyond in Canada could be infusing at home themselves with adequate education and preparation. Something that hasn't been as available in Canada as we might have wished. I wanted to talk a little bit about the nuts and bolts, but Dr. T has preempted me. I know that many of the questions that Angela has received have been about, well, where do I get it? How do I get it? And those answers aren't absolute at this moment, but you can imagine that I've been talking to Angela, folks at Takeda, folks at Canadian Blood Services over the last few weeks, trying to sort this out, and you can be assured that everybody is dead keen on getting Glacia and augmentation treatment out to the patients who need it. And so my schedule has just been bent over the next several weeks as meetings are taking place to hammer out those details. Everybody is working with the best will in the world. So you'll get your concrete answers, but you've heard a bit of an outline. The blood product comes through a slightly different route, through the blood banks, no surprise there, and then is almost certain to be infused in one of the large infusion clinic chains that we have across Canada. A little change, not a very big change, so relax if you've been worried. This is a work in progress, and when the details emerge, nothing much is going to change. I wanted to say something else that's tremendous importance, and this, I think, has not yet been said, but if you're paying attention, you might have guessed at this. Alpha-1 antitrypsin therapy with augmentation has been around for 30 years. It was picked up very quickly in the United States, Germany, not quite so quickly in Canada, and it's becoming available in a number of European countries in South America, but there's still many countries who don't have it. Up to today, augmentation therapy, different brand names, including Glacia, has been distributed in the drug system as a prescribable drug. No other country in the world has taken this step to put this blood product in the blood product chain. It's Canadian first. It has huge implications. And I know that other countries are interested. Angela's starting to get some international calls wondering how she did this. This is really, really exciting. So yes, it's a game changer for Canadians. This could be a game changer for alpha-1 antitrypsin deficient patients around the entire globe. It is an amazing story. Good stories often have heroes, and that appellation certainly describes some of my patients, some of the advocates. You've heard today from people with lots of initials after their names and people who are wielding multi-million-dollar budgets, and those are all people who've been working hard and have been doing their jobs, and many of those people might be the heroes in this story. But I think the hero in this story appears on the scene about 7 years ago and looks and says, my goodness, there are people who are becoming more and more breathless, losing their lives prematurely. They need something, and the something isn't a pill. It isn't something manufactured in the lab. It's a blood product. My goodness, why do they have to go to insurance programs with a drug insurance number in order to get their treatment? Why do they need private insurance? Why doesn't this come like all the other blood products, like the ones that people with hemophilia get, like the patients receiving chemotherapy get? Canadian Blood Services has been asked about this before and hasn't previously picked up this suggestion. So when I saw Angela begin to start tilting at windmills, I wished her Godspeed, but this was an impossible task. Not so impossible. And I think we should all give our thanks to the hero of the story, Angela. And tomorrow she takes on the rest of the world. That's the plan. Thank you.
I told you I didn't want to cry today. So sorry, Mark, but before that you have to come up after that. But before we go on, thank you, Dr. Chapman. I'm going to try my best not to cry today. Happy tears. Before we move on to our panel discussion and open things up for questions, I do want to bring up Mark Delvaux to offer greetings from Elphanet, Canada. I have had the pleasure of working with Mark and his team for many years, and we are thrilled to have them here with us today in Calgary. Please help me welcome Mark Delvaux.
Whoa, I almost went down. Thanks, Angela. Thanks for the invitation, Gary. I appreciate it being here. You know, Elphanet Canada really started as kind of a byproduct of what we had going in the U.S. in 1999. Our founder, John Walsh, who was really a tremendous tornado of a man, a human being, started Elphanet in the U.S. He started Elphanet as a way to provide more impact, health, quality of life for alpha patients, and to raise money for research. Over what are we in our 24th year of disease management services through Elphanet in the U.S. We've raised $70 million for research. Some of what we see in the pipeline today was learned through the research that we did. In 2014, John wanted to make sure that alphas in Canada had the same services as what was available in the U.S. So he started Elphanet Canada, and that Elphanet Canada consists of a board that's majority Canadian and also a majority alphas. The first board had Dr. James Hogg on it, so not too bad, right? And now we have Dr. Chapman in it on our board as well. So we've had really terrific leadership in the medical field. We had Dr. Sandy Sandhouse, who's been our medical director for 10 years with Elphanet Canada and has worked with the coordinators and the people in our board as well to make sure that we provide the highest impacts for our patients. Let me see if I get this. Angela, there we go. So today's board, the medical director, again, we've been here 10 years. Today's Canadian board consists of Bob Green Jr., who is also chair of the of Elphanet in the U.S., Dr. Chapman, Vivian Rossi, Michael Johnson, Randall Plant. Again, majority Canadian, majority our Alpha 1 patients as well. When John Walsh set up Elphanet in the U.S., he came up with a brilliant idea. John had a lot of brilliant ideas. The man was incredible, and his idea is that we were going to provide disease management and health management services through coordinators, patient coordinators, we call subscribers, or excuse me, patients we call subscribers, who are Alpha 1 patients that had the genetic condition. When I first started, one of the program managers told me something I never forgot. She said that there is nothing more powerful than one patient speaking with another patient. And that's been our model. We have 70 coordinators in the U.S. We have 6 patient coordinators here on our Elphanet Canada team. That cross all of Canada. We serve just a little under 500 alphas. Not all are fusing. One day they all will be, thanks to Angela. Thank you. And those coordinators reach out mostly through phone calls, and you can see there they've either fielded or made approximately 6,500 calls in a year. So what do these coordinators do? They run our health management program. The health management program consists of asking on monthly calls how people are doing, what has their experience been, have they been to the hospital, have they had an exacerbation, and we do this, throughout North America. From the work that's been done, we have published on the patient journey, Dr. T mentioned, 60 peer-reviewed papers, including papers that showed that the health management program that's been developed, again, by Dr. Sandhouse and others, helps reduce ER visits, exacerbations, unscheduled doctor visits, has improved use of corticosteroids, and also has increased and produces a very high level of compliance on meds, including augmentation. We also have a quality program that we run where we have 10 quality health managers. They change 1 or 2 a year maybe. So what are the 10 things that patients can do, Alpha-1 patients can do, to give themselves the best chance for health and quality of life? So includes things like making sure you take all your augmentation. Have you done all your infusions? Have you had your lung test? Have you had your liver test this year? Have you had your flu shot? So quality measures similar to HEDIS and some of the other quality scores that are necessary, like in the US and Canada as well. So those are really the makeup, but the power and the reason this has all worked for 24 years and we've been able to raise $70 million for research is this, right? It's alphas serving alphas, it's patients talking to another patient. So what does the future look like? We've talked about John in the past and where we're at now with Alpha Canada. And I think the future really is up to everyone here in the room and also listening in. Are we going to take advantage of the opportunity that's been presented that Angela and Dr. Chapman and the AlphaNet or Alpha-1 Canada board and patients work so hard for? If we are, then it's going to take all of us individually to maximize the benefit, to maximize the impact we can have on each alpha's health and quality of life. So that's our challenge, and I look forward to working with Angela and Dr. Chapman on our board and pushing that forward. And we've done work, Dr. T, with Innomar here in Canada, and I can't tell you how happy that makes me to hear that. They've really done a terrific job, and also One Path in the U.S. So looking forward to that as well. So thank you again, Angela, and Gary, if you can look back and say, the board can look back and say, one day if we did one thing right, we got it right with Angela. So fantastic and way to go. Thank you.
Is there a competition to who's going to make me cry first? So I'd like to ask Dr. Grenet, Dr. Boutani, and Dr. Chapman to take their seats on the stage as we open up our question period. While they're doing that, I'd like to remind everyone we are going to do our best to answer everyone's questions today. Thank you. That said, many of the questions are similar in nature, so please bear with me if I don't directly quote your question, if it is similar to someone else's. In the new year, we will also have a dedicated webpage for all the frequently asked questions for both patients and physicians on our website in the new year. We are monitoring the info@alpha1canada.ca address right now, so if you haven't already submitted your question, please use that email, and I am here juggling them, and will ask anyone here on the panel the questions that you're sending in. And it doesn't surprise me, a question that I have been getting a lot this week is for Dr. Grenier. Chris from Newfoundland has written in, as have many, how do I find out the cost of my treatment?
Well, the good news for Chris is the cost for him is nothing.
I like that answer, yeah.
And that's true for all patients as well. The cost of therapy, the cost of the product obviously is confidential. That was negotiated and with the RFP. But the way it works on the financial side is that when CBS sends the product to the blood bank, the province of that blood bank pays for the bill. That's the end of it. Patient sees nothing. On the pilot we're doing in Alberta with the specialty pharmacy, I'll just repeat it because I said it in my presentation, the model stays the same. When we send the product to Bayshore Pharmacy in Alberta to then be shipped to the patient, the Alberta Ministry pays the bill, not the patient. So the patient, zero cost to them.
Great. Thank you, Sylvain. Dr. Grenier.
Oh, Sylvain's fine.
Thank you. Ken from Ontario is asking, will it be necessary to have a new blood test to determine a patient's level? Did you want to take that one? Yeah.
Sure.
Yeah, thank you.
Again, we're still hammering out the details, but I think that depending on what the blood test was, genetic or serum level, and when it was taken, and if it's available, it may not be necessary to do more blood testing. The thing that's probably going to need to be current, and I'm not sure if that means within 6 months or a year, would be the breathing test, which is also part of the criteria. But presumably, if you're under the care of a doctor for your alpha-1 lung disease, there should be some breathing tests around somewhere. That might be the thing to keep current.
Great.
Can I add to this as well?
Absolutely.
Because my team at CBS will also be monitoring the patient registration to get the approval and the criteria. And I had a discussion with Dr. Chapman before. For patients that have been on Prolastin for many years now, well, the blood level might not be accurate, right? And we're not going to ask patient to be out of treatment for months to prove that they have a deficiency. So again, we have to nail down the details. We've talked about the implementation team. We will have experts on that team, and then we will be discussing what will be practical for the patient. But again, what we want is for patients to get the treatment they need. So we're not going to come with crazy ideas of stopping treatment just to prove a point.
Thank you. Did you want to, there will be a hand mic, so if anyone in the audience wants to ask a question, Pam will be within the room and have a mic. Please just raise a hand and we'll take your question. A question from Rick in Ontario, I think Ontario. Good to hear BC patients won't be taken off Prolastin, but for those on private insurance, until it is available through new producer, but who will be paying for the product in the meantime?
So I can take that. Well, so I'll just clarify. So I'm not saying that BC will continue to pay Prolastin forever, but what they've confirmed with us is they will not stop providing Prolastin in the short term. So we will be in discussion with them, and that's to ensure that all patients gets transitioned to Glacia before they remove Prolastin. Now, on the private insurance side, we do have regular contacts with them as well. We're not in control of their schedule. Normally, the company, the insurance company, do tend to try to cut products sooner than later, but we'll be in touch with them as well to make sure that they don't do it like too early on this aspect. But the ultimate goal is that every patient that has a need for an alpha-1 antitrypsin will be on Glacia. There will be no more need for insurance and no more need to go to the province because ultimately it will all be coming from CBS.
Great, thank you. I think I know the answer to this question, but it's for you, Sylvain. Karen in St. Catharines would like to know if she can donate her plasma specifically for her cousin who is an alpha-1 patient.
The way plasma works compared to blood, when people give blood, the blood is re-identified to the patient and goes to a specific patient, although we don't link the patient and patient don't know that, but we have the full traceability. Plasma, we also have the full traceability, but if you remember the video on plasma, in order to get immunoglobulin or alpha-1 or something like that, we pool the donation of thousands of donors to go in the production of those products. So we can't say, well, the plasma donated by Karen will go to her cousin. Definitely, it's not something we can do. And in fact, to be fully transparent, at the moment, the plasma we collect in Canada is not being used to produce alpha-1 antitrypsin. So what we're collecting is used to produce immunoglobulin, albumin, fibrinogen concentrate, and some factor VIII with von Willebrand disease. Now, we may look at adding more products in the future, but at the moment, it would not be going for alpha-1.
Thank you. I know this may come as a shock to you, Sylvain, but the patient community is still in what I would think shock. So here is a question from Shelley in BC. Do I still send in my annual family income information to the company every year? You've already, so in BC.
Oh, okay, for the insurance company?
Right.
Yeah. Again, no, like for us, CBS is not an insurance company. We are a wholesaler of blood product. We're a blood manufacturer. We're a formulary manager, but we are not an insurance company. So we couldn't care less about the revenue you're making. Products are provided for free to the patient, paid by the provinces, upfront by the provinces.
Thank you. I really think people are in disbelief about that, particularly the alpha-1 patient community. Patricia is asking, what will happen if Takeda cannot supply enough product to handle all the new patients? I'll open that to...
I can start. So right now, we don't anticipate that at all. So in terms of plasma-derived product, there is one product that is short globally. It's immunoglobulin. I've mentioned that before. One of the reasons is because you don't have as much immunoglobulin coming out of the plasma than other product, and the demand is quite high. Albumin is probably the other product, not in Canada in the near future at all, but some countries are starting to see a problem. All the other product, there's more than enough plasma being collected to produce the product. So alpha-1 is in that situation. We don't foresee any problem with Takeda to get our supply. We have a very robust demand forecasting process to request to request the various products from the companies. And as I mentioned in my presentation, Takeda, all the manufacturers of plasma-derived product in Canada, have a contractual agreement to carry several months of product in Canada, and we do the same at CBS as well. So I have no concern being able to get that. Now, if a major disaster was to arrive, we've seen with the pandemic, again, the only product we had concerns with was immunoglobulin, and CBS took the necessary measure to acquire more product from other manufacturers to make sure that supply would be provided. So we don't know what the future may look like, but if there's something major happening, Takeda is not the only producer, so if Takeda, there was a challenge, then we would reach out to other manufacturers as well.
Go ahead.
I'm just going to add that it's not a naive question from the questioner, because there was a global shortage of alpha-1 antitrypsin. Date escapes me, late 80s, early 90s. And it's unlikely to happen in the near or medium future, but I think it behooves us to use the resource wisely for people who truly need augmentation therapy and in an appropriate dosage.
Thank you. Dr. Chapman or Dr. Bitani, will those with, this is from Bridget, will those with defective genotypes be eligible for augmentation therapy? For example, genotypes such as F, as in Frank, Z, and FF, which have higher serum levels similar to MZ and MM, respectively, but protect the lungs more like ZZ. Thanks, Bridget.
There's a question from somebody who's deep in the weeds of alpha-1, and just for the listeners who haven't heard about this before, the F, as in foxtrot, gene is a tricky one. It produces alpha-1 antitrypsin protein in normal or nearly normal levels, The problem is the protein doesn't work, it's broken. And so just measuring serum levels is deceptive. It looks like there's enough alpha present, but we know from the genetic studies that it's not working. Maybe I'll do the supplemental question sideways to Sylvain. If serum levels don't correspond to what we know is really going on, can we plug in a genotype? And I suspect he's going to say that's one of those implementation things we have to solve. Okay.
The only additional point I would say is the way it works on the CBS side, as I mentioned in my presentation, CBS is not the one that approves the criteria. So the criteria that were presented in our customer letter were approved by the Conference of Deputy Ministers based on our recommendation, based on the cadet recommendation. If we want to diverge from the criteria, there's multiple pathways. The one that exists right now is the exceptional access process. So on a patient-by-patient basis, we can review. So if a patient does not meet the criteria, there's still possibility for that patient to access therapy, but there needs to be a clinical argument to be made. So the specialist needs to make that clinical argument, and the province, and then in that case, it becomes a specific province where the patient lives, because that's the province that's going to get the bill, have to approve it as well. So I'm not saying that it's going to be easy or it's going to go through, because we haven't been through it with alpha-1. It is very seldomly used normally for other proteins as well. Now, over time, the criteria could evolve. If we find that there's better ways, we might have an opportunity to update the criteria, but at the moment, it's going to be more of an implementation issue for sure.
And just very quickly, if people are listening and they wonder, well, is that going to affect me? The F variant is comparatively rare, so it would be just a few people who might be affected by this and have to go through a slightly more complex process. And you've already heard from lots of people in the room who could bring the expertise to bear for a slightly special application.
Just to maybe add one point to that, since 2012, the last iteration of the guideline, the knowledge on this is expanded, and one of the questions we're looking at with the guideline is the who. And so perhaps as guidelines get updated, indications change, and these sorts of things will evolve with CBS over time.
Thank you for mentioning that, Dr. Kenny, because we have heard from several respiratory therapists this past week wanting to know what, if any, will the changes be with the new guidelines in the spring. I don't know if you can speak to that. It's a little premature.
Yeah, I mean, I certainly can't speak to what the recommendations will be, but the literature search has been done. The questions we're asking is who should we screen, and then who is the treatment beneficial for, and then there'll certainly be an update on that recommendation over the next few months. But they're in the process of doing the methodology now in terms of the data analysis. So stay tuned.
Thank you. Speaking of criteria, I have had the pleasure from hearing from a number of frustrated physicians recently. Why are internal medicine specialists not able to prescribe augmentation therapy? Why does it need to be a respirologist that prescribes? And I will let anyone answer on the panel.
I don't want the hate mail.
I can forward it to you.
I will simply say, and Mohit spoke to this earlier, that this is a highly specialized area, and that there are a great many pulmonary specialists who need to get up to speed, and they will through revised statements and educational programs. I think that it does make some sense that the unique characteristics of alpha-1 antitrypsin deficiency emphysema be documented by a pulmonary specialist, by a respirologist. And I would hope that if that's not somebody who's readily available in a town or village, that there would be some access to some sort of pulmonary review, maybe even virtually. We've learned a lot through the pandemic that would allow such expertise to come to bear. These are critical lifetime decisions, and most pulmonary specialists only have 1 or 2 recognized alpha patients in their practices. If I were a busy general internist, I not sure that I would be able to master alpha-1 and all the other stuff I had to do. So, sorry, maybe the hate mail is going to start, but I'm good with the respirology recommendation. But maybe we need to work hard to make sure how respirology expertise becomes available in places where it's not easy to access. Thoughts about that?
Yeah, I would 100% echo that. I think this shift in terms of how the medicine is not going to be available is a seismic change, right? And so I think to your point is that I think we need to educate our specialists first. I think there is a wide gap in terms of the knowledge base when it comes to alpha-1 antitrypsin deficiency and the genetics associated with it and those sorts of things. So I think we take small steps, and I think as this transition takes place, as the nuts and bolts are sorted out, I think it's a long-term vision because access is a problem to specialist care. And I think that would be something to think in the long term, but I think we got to take sort of small steps, integrate it, make sure it's effective and we're doing the right things for our patients, and then think about a bigger picture strategy.
This reminds me, just by coincidence and on a different matter, I was here in Calgary 2 weeks ago, and some of your colleagues were providing acute care, in fact, in what used to be called the Northern Territories and in Northern Alberta and remote areas. So there are programs in Canada to address this. This must crop up in other blood product areas.
Absolutely,
that, yeah.
Absolutely, yeah. Yep.
Okay, known problem, we'll fix it. We'll address it.
Sylvan, a patient is asking, how will my respirologist know how to prescribe, and where do they send the prescription to?
So again, we'll arrange the details in the implementation team. The typical patient journey right now, and Jefferson mentioned it a little bit, the patient would get their prescription, and then the patient is registered in the patient support program. The patient support program often will help with all the coordination and everything. The prescription has to be sent or brought to the blood bank, and then the blood bank is the one dispensing to the patient. In Alberta, with the pilot, it may be through that pharmacy. So we'll see how it goes, and if it's through that pharmacy, Alberta, you may be aware, they've gone through the provincial electronic health record that's been implemented, meaning that any physician, I assume respirologists in Alberta, all have access to that EHR as well. When they prescribe it, it goes electronically to the pharmacy right away. It would be also going to the blood bank. Other provinces may not be working exactly the same. But the fine details will definitely be worked on with the implementation team to see how it's going to be working.
In terms of the doctor access, it's an interesting question, and I think that's something the CTS might want to be looking at. I'm sure we'll be looking at. But I would say that in this sort of rare disease setting, a bit of a Google search will help you find Alpha-1 Canada, AlphaNet, and if you start talking to these folks, you will be able to identify physicians who are involved in Alpha-1. And I can't speak for the others, but I suspect that if you were to, as a physician, have the name Paul Hernandez on the East Coast, or Francois Montet in Quebec, or Ken Chapman in Ontario, and send off an email, not the patient, the physician, hey, I've got this patient with such and such and such and such, what do I do about so-and-so? We'll just answer that. That's what we do. Rare disease settings are ones that we understand require some special expertise. If your doctor hasn't dealt with it before, there will be help out there. It's a very fertile phone-a-friend sort of territory.
For those that are, sorry.
No, go ahead.
I was saying, for those patients who are already receiving replacement therapy or augmentation therapy, you're probably familiar with the patient support programs. For those of you who are not being treated, these are very well-designed programs that are, I would say, there's not a respirologist in Canada who's not had some sort of experience with these programs, and they actually work very effectively and very efficiently, and we often find, surprisingly in a good way, from the time of submission to the time of treatment, the window is very narrow, and so the turnover, the process is very efficient. So I think that's just rest assured that I think these things are well-oiled machines, and not to worry about those kinds of bumps with that PSP program.
Yeah. And the other piece I'll add as well, I mentioned about the prescription, but because Glacia comes with criteria, there will also be an eligibility form that will need to be filled and sent to CBS. So the details on how it happens will be communicated later. We have other products like this on our formulary, so the physician would then fill the information. We try to make it as simple as possible, so the criteria are listed there. If there's a serum value that is required, we're requiring this, it's there. Sent to my team, approval is done very quickly. The policy says 30 days, normally it's like 2-3 business days it's done, and then that allows the blood bank to be able to dispense it as well. But again, those details will be communicated further as well. They're already on our website, so it's going to be, part of that implementation is going to be for the community, physicians and patient, to understand how it works with CBS, but all the information is there.
Thank you. Sylvain, I think you've kind of answered this two-part question. So my current therapy is delivered to my home. Will that continue? And then the follow-up is, I'm receiving infusions at home. Will that continue?
Okay. So in terms of delivery at home, in Alberta, if it goes through the specialty pharmacy from Bayshore with the pilot, yes, the answer will be it will be delivered at home. The other provinces, unless we get different direction from the ministries, unless they decide to jump in the pilot program or it expands, the model will be that the patient will have to go to the blood bank to get their medication, which is what's happening for all patients in Canada that are requiring plasma-derived therapy. Patients on immunoglobulin, patients that have hemophilia, patients that have hereditary angioedema, they go to the nearest blood bank to get their product. But hopefully, well, I don't know what long-term may mean, but with the pilot we're doing in Alberta, what we're trying to do is for patients that receive product to be used at home or in those infusion clinics, that they don't have to go to the blood bank and then it's delivered at home. But it's not going to be quite ready yet.
Thank you. There's an audience question. Hi, Jackie.
It might be a little early to ask this, but for people who travel, between provinces, for example, and maybe gone for, I plan on spending 4 months of the year in BC and a resident of Alberta. Would it be seamless between the provinces? Is the first part of my question. And the second part is, if you travel outside the country, specifically to Europe, for more than a 2-week time frame, how easily accessible will your infusions be while you travel?
Okay. So in terms of access to the product, anywhere in Canada except for Quebec, you'll be able to access it from a blood bank. So it's not going to be a problem at all. If you go for somewhat short term, like 3 to 4 months, you might get the supply from your home blood bank and then go and travel with that supply. We do have patients, I don't know how realistic it is for alpha-1, but we do have patients with other diseases that take plasma protein and go 6 months in Florida. They get their supplies before they go, they bring them with them. Now, I don't know if it's realistic for alpha-1. I don't know enough about the disease, the supply, and all of this. I know that Jefferson mentioned it. Most of the patients that are receiving plasma protein at the moment receive training for self-administration. Doesn't mean, again, that's going to be realistic for all alpha-1 patients, but patients with hemophilia, they do give themselves IV infusion multiple times a week. They get trained to do that, and then they do it at home, and they have much more freedom doing this. So hearing what Jefferson has mentioned before, he's mentioned that the Innomar Clinic, part of the One-Path program, will continue to give infusion in the clinic. He's mentioned the ability to train patients so they can do the training at home. So I think all those options will be made available for patients. Now, moving to Europe, again, same thing. It's not a problem to bring the supplies with you and being able to do self-administration if you've been trained and you're comfortable with doing that. What may be a challenge is going to be the volume of the product that you may be requiring, depending on how long you would be going. Now, one thing I can tell you, CBS cannot ship outside of Canada. So you would have to pick your supplies before you leave, or having to come back if it's an extended period of time.
But the patient could take it with them.
Yes.
It just won't be shipped.
Yes.
I just want to clarify that. There are a lot of questions about travel, so thank you for asking that, Jackie. And there are a lot of questions that all ask the same thing. Will self-infusions be an option? And I think you've addressed that, and Jefferson addressed that earlier.
Absolutely. With the proper training,
absolutely. With the proper training. It's not an option for everyone, but we have a lot of emails asking about infusing at home. People are referring it to self-infusions or self-administration, so thank you for asking that. Another question related to criteria. I live in BC and I had a transplant 6 years ago. I've been receiving weekly infusions since. Am I to understand that I'll now be taken off treatment? What if my respirologist recommends that I stay on treatment?
Well, this goes back to something I was trying to say. I think there's good reason to think, hypothesize, that augmentation would be useful after transplant. One of the other things that augmentation can do is work as a tremendous anti-inflammatory. So hypothetically, there may be less difficulty with rejection and the lung scarring process that happens to some transplant patients called bronchiolitis, a damage to the airways. But I keep saying the word hypothetical. Most transplant programs in the world, and certainly in North America, do not infuse alpha patients post-transplant. Some do, and obviously that's the case for our patient from British Columbia. This is going to sound a bit rude of me, but I certainly wish that patients from British Columbia, including the transplanted patients, had joined the Canadian Registry and other registries so that we could gather up all this data and actually have some evidence, one way or the other, as to whether or not this works. So please, look for the registry in Canada, join, let's start gathering this information to answer those questions. As for today, when we don't have that information, I guess I'd turn to Silvana and say, I guess this fits the exceptional access model if the respirologist wants to continue infusions and the post-transplant patient has normal lung function and doesn't meet that criterion, it would go that roundabout route through the committee you were describing.
Absolutely. Because, I mean, right now that one might be even more difficult because it's actually a discontinuation criteria if they had a transplant. But the exceptional access is designed for that, so we can do a patient-by-patient review and determine. So it's not going to be guaranteed that if a patient qualifies for that, doesn't mean that all patients will qualify. It's going to be based on the value for that specific patient.
Again, the concept of the blood bank, I think, is foreign to the Alpha-1 patient community, right? So this is new. And I'm getting a lot of questions, and Scott has just sent one in saying, will Innomar be a blood bank for the new product?
No. So Innomar is, currently the infusion clinic where prolastin is being given plays two roles: the distribution of the product and the administration of the product. In the future, with Takeda one path with Innomar, they will only play the administration role. The distribution role will be done by the blood banks or Bayshore Pharmacy if we go through the pilot. So this means that the patient has to go to a blood bank to get their supply, and the administration could be done at home if it's self-administration, or it could be at the clinic. But again, the implementation team will be discussing that. Typically, the way it works for most patients in Canada that are using product from the blood banks, they do tend to receive 3 months supply at a time. I don't know if it's going to be the same for Alpha-1, but this is what the practice is right now. So it could be expected that patients would get like 3 months supply at a time, and then when they go for their injection, they bring whatever is needed for their injection on that week, or they self-administer, which is often what happens. And then in that case, there might be another question that's going to pop out. Well, 3 months supply of Glacia, what does it look like? Well, depending on the dose you have, it can be it's a case of products. But we see that with patients that are using sub-Q IG at home for different conditions. It becomes part of the practice that maybe they have a small bar fridge that is dedicated to their supplies at home. So it's something that patients will have to probably start considering. It does provide a little bit more freedom. They have their supplies at home and they can inject themselves. So it is one of the change that will be happening. And again, with the implementation team, we'll see how realistic and how problematic can it be for Alpha-1.
Thank you. Dr. Chapman, what are the risks of changing brands?
fear and anxiety, which I hope we've dispelled today. No other side effect or problem that I can think of.
I like that answer. That was good. Are Glassia and Prolastin equivalent? How do I know this? Anyone?
Well, I can go, if they're willing to read literature, there's actually a study that compared Glassia to Prolastin and showed Glassia to be non-inferior to Prolastin. The technical term for non-inferior doesn't mean it's the same, but it means that it does the same thing. So there is actually, in the rare disease space, it's very rare that we have that type of studies. And in the case of Glassia and Prolastin, that exists. But as we've mentioned before, it's the same protein coming from a group of thousands of donors. Whether it's fractionated by Takeda or Grifols, it's the exact same protein that ends up in the vial.
I'll just say that in the Alpha-1 community, when I meet with people like Sandy Sandhouse or Mark Mirovitlis or the other names you've read in the literature, we never talk about different brands or products. It's a protein. It's purified alpha-1 antitrypsin protein. I know it's a bit disconcerting in Canada because the only product that's been available, and we've kind of used it as a catch-all term, the way we talk about facial tissue as being Kleenex. Well, there are lots of different brands of facial tissue. There are a bunch of different purification methods that lead to alpha-1 antitrypsin augmentation therapy, but it's really all the same stuff. Prolastin got early to the Canadian market. Canada's a relatively small market, so it wasn't worth anybody else jumping in, and it's just happened recently, but around the world, Glassia is well known. So are other brands. It's really all the same stuff, and this is not a point of discussion or debate amongst people in this scientific community.
I think what's coming through here with all the questions, I think it's really important that you've got Alpha-1 Canada advocating for yourselves. Yourselves are advocates for yourselves as well. So I think it's really important that you speak with your respirologist and make sure that they pay attention over the next several months to guidelines, to process, to be aware, because the transition is going to happen, and you want to make sure that your clinician is aware, because this is a natural change, and I think it's important for you to be an advocate for yourselves.
I'm pretty sure there's a patient advocacy website that will link to or have those guidelines available. That's just a hunch.
Yeah, that's good. This is one for Dr. Butani and Dr. Chapman. It will be an interesting discussion. I am an MZ. I've been on treatment for 10 years. Why do MZ patients not qualify in Canada?
There is no evidence that patients who are carriers need or benefit from augmentation therapy.
That's it. I'll go back to the guidelines and talk about the scientific rigor that we go to make sure that we get patients the right treatments, and I think you have to rely upon the science, and that's, I think Ken's summarized that quite nicely.
Thank you. I like a simple, that's quite simple. The other question, and I shared it with Dr. Butani earlier this week, and there's similar ones coming through. We have patients that would qualify but are hovering above 80% lung function. We had one gentleman, and he echoes a concern from a number of alphas that have been living in regions with wildfire smoke. And they're worried about delaying getting on treatment because they don't have that protection.
If I can jump on this, I'll try and bring you into the doctor's office, and doctors do blood work all the time, and it generates a whole lot of numbers and results. And what makes it a bit simpler to deal with as a doctor is the lab helpfully prints all the normal results down the middle of the page, and the abnormal ones it prints over on the right-hand side in a specially shaded column. So there's the abnormal value I have to deal with. Here's where it gets tricky. If you're a carrier, you have slightly lower blood levels of alpha-1 antitrypsin than the average person. that puts you over in that right-hand column. It's abnormal, but people in the alpha-1 antitrypsin community understand that those values of 80 and 90 and 100 might be abnormal in the lab that you go to, but it's plenty of alpha-1 antitrypsin to keep your lungs safe. It's the values of 20 and 30 that cause us a great deal of concern. Now, back to Canadian pulmonary doctors, or doctors in general. We all learned about alpha-1 antitrypsin in medical school. We learned enough to pick answer B on the multiple choice exam and get it right. That's about as much as most doctors know. So do your doctors, family doctors or pulmonary doctors, carry those numbers in their head and understand that a slightly low level is of no concern and is probably a carrier status? Maybe not. And so there may be a whole lot of people who've been told without qualification they have alpha-1 antitrypsin deficiency, implying a severe deficiency leading to emphysema, who are in fact carriers, who are perfectly safe and just need to be told not to smoke 2 packs of cigarettes per day. This opportunity is wonderful to bring Canadian doctors up to speed and make sure that appropriate care is being managed. I wanted to get back to the patient who says he or she is an MSAT, I'm channeling American here, and has been getting infusions for 10 years. I would add up all of those hours of sitting there getting an infusion and thinking that's a real hit on quality of life if you don't need it. And by the way, we've already talked about potential shortages, not that we expect any, but it has happened in the alpha-1 antitrypsin community a couple of decades ago. We want to make sure the protein's wisely used so that there aren't shortages and that people actually need the stuff and get it.
Thank you. Sylvain, a patient is asking, if I have an adverse reaction to Glacia, will Prolastin still be available?
So the formulary, again, through the exceptional access, could bring Prolastin, but I can't. It would be very surprising to have a patient react to Glacia and not Prolastin. So, I mean, nothing is ever impossible. We've seen that with other products that we carry, that sometimes a patient doesn't respond well to a brand and we have the other brand as an alternative. But the likelihood of that is very, very slim.
And a quick clinical add-on to that. The purification processes for alpha-1 antitrypsin have evolved over time, and what used to be common side effects are being seen less and less often. So in the early days with early formulations, people might have an infusion over 20 minutes and feel sort of achy and out of sorts for the day, and the common advice would be to slow down the infusion. I don't hear about those side effects very often, but I'll just offer this thought. If you have some minor out of sorts feeling with your first infusion of what is available, work with your respirologist, work with your infusion team. This may be minor and inconsequential and not specific to any brand. It may be your body getting accustomed to this infusion of new protein it hasn't ever experienced before.
And I think the key, and I think as you said, you're not going to a generic version of the medicine, right? This is brand to brand, and so that's the standards are, especially for blood products, are quite rigorous. So I would tend to echo those comments. Yeah.
Okay, I'm getting other questions coming through about patients above 80% lung function and forest fire. I don't know if you want to address that.
Yeah, so the question is, the earlier question was if you're ZZ and you're low, so clinically low, and you have preserved lung function, and that's a challenge. And it's a challenge. I've got a couple of patients who fit that exact criterion. The problem is that the science, the studies are in this particular population of patients where they've been shown efficacy. So generally FEV1's lung function between 30 and 80%. And so it's the science that's driving those decisions. I would echo Ken's comment that if you're that patient, be in the registry, because I think those are the kinds of novelties that we need to study and need to enhance it. And so, again, there's some literature on this. The guidelines are reviewing all that literature. Perhaps in the spring of next year, summer of next year, maybe the recommendation changes if there's new evidence that suggests that population benefits. But right now, it's the science that drives the recommendation. I don't know if, Ken, if you got, yeah.
It's an interesting area. The ZZ who's got normal lung function, great, congratulations. And one of the learnings for me in getting involved in alpha-1 antitrypsin was discovering that not everybody gets lung disease, thank goodness. And obviously there are other factors. Smoking is one, but the other factors are things that we're too dim to yet understand as doctors, other genetic factors that have yet to be hammered out. So the goal, I think, with the alpha-1 patient, and maybe we should try and put something on the website, maybe write a paper about this, is protection early on. And the current concept is augmentation is reserved for people who have all the bad factors in place and show signs of obstruction developing, signs of emphysema developing. And we want to catch those people early before there's much in the way of symptoms or problems and prevent further decline. So it's not as though we only wait to the bitter end to start the preventive treatment, but we want to see that there's at least something going on that's bothering the lungs before we use this precious resource.
Thank you for addressing that. Sylvan, patient is asking, how do I get all the supplies to self-infuse, like syringes, needles, etc.?
So all of this is provided by the patient support program. So what happens typically for patients that are receiving or that are self-administering at home with other products, they are receiving those supplies at home delivered by the patient support program. So one path would then be sending that to the patient's home.
Great. Thank you for answering that. Raylene is asking a question. My mom is 80 and doesn't drive. She gets her infusions at home with the nurse. Will she be able to do that still?
Most likely, I mean, that from what I heard from Takeda, they will have nurses that will be able to go home, and they're using Innomar as a partner. So I suspect, I mean, Takeda would have to answer on their patient support program that it will still be available for the nurse to be able to go at home to administer the product.
Thank you. This is specific for Alpha-1. I have a woman asking, she was not on treatment when she had her first child and trying to have another child. Can she remain on augmentation therapy throughout her pregnancy?
I don't think there's any study, again, rare disease and a study of augmentation therapy during pregnancy, not to my knowledge, been done, but I can't see why that wouldn't be reasonable. I would, all other factors being equal, advise continuing infusions during pregnancy.
Yeah, 1,000%. Yeah, I could not see a rationale to stop. Yeah.
I think Jefferson addressed this, but for you, Sylvain, where is Glacia made?
He mentioned it was made in Belgium, I believe, so that will continue to be made there. Like all plasma protein that are produced around the world are made either in the US or in Europe. Now, there is a facility in Montreal that Grifols acquired a few years ago and will become operational very soon to produce immunoglobulin and albumin, but not for alpha-1 at the moment.
So just to underscore, people are concerned about the shift from Prolastin to something different, but Prolastin is not made in Canada either. It is not made in Canada.
It's made in the US, yes.
None of the therapies are made in Canada?
Exactly. Okay. At the moment, none of them.
Thank you for mentioning that. All of the questions are now echoing questions we've already addressed. So I think what I'd like to do is wrap it up today and let everyone know that we will have a frequently asked question page on our website. You can, of course, email myself at the info @ most people watching today know how to reach me. And I'd like to thank everyone here today. gentlemen, the stage is really squeaky, so you're welcome to stay sitting here on stage while I give a very long and hopefully tear-free sign-off here today. Because there are a lot of people that have made an impact, both big and small, along this journey to get national access. Not only have they made an impact on patients' lives, but they've certainly made an impact on mine. The Alpha One Canada Board of Directors has been a tremendous support. And though I'm sure they were probably perplexed about some of my approaches, they remained supportive and put their trust in me, and I have sincerely valued that. To my colleagues at Canadian Blood Services, what a ride it has been. After 13 presentations before 3 different board chairs, dealing with 4 lead province transitions, multiple changes in governments, and numerous iterations of the PPRP review process before Sylvain. Through it all, the CBS board and executive management were patient, and they remained open to finding a pathway that would ensure equitable access to treatment for Canadian Alpha-1 patients. Many thanks to Steph, Chris, Ellis, Andrew, and a special thank you to Dr. Grenier and his team, and of course to Dr. Israel Levy and Dr. Graham Shear. In the last 6 years, there have been too many shifts in our governments to mention, but through those transitions, I would be remiss if I did not give a special thank you to Assistant Deputy Ministers Patrick DeCerny, Chad Mitchell, and Mitch Monio, as well as Mr. Monio's colleague, Catherine Logan. These ADMs have been responsive and sincerely committed to finding a way to get patients access to treatment. The Canadian Agency for Drugs and Health Technology, better known as CADTH, they don't get a lot of thank yous because they can be challenging to engage with. But again, I would be remiss if I did not publicly thank Brent Fraser for his responsiveness and transparency. The initiative to get national equitable access for Canadian Alpha-1 patients highlighted the importance of collaboration between governments, the blood system, industry, and health technology agencies, and Alpha-1 Canada. And I can tell you, there was a lot of collaboration to get this over the finish line. The work could not have been done without corporate sponsorship throughout the years from Takeda, Grifols, CSL Behring, as well as Alphanet Canada. I'd like to thank Takeda for sponsoring today's session, and more importantly, I would like to thank the Takeda leadership team for all of their efforts to see this initiative through. Many thanks to Root, Asher, and of course Dr. T, but also their associates, former and present, Norm, Christina, and Michelle. There are many industry colleagues that I need to thank today because it truly does take a village, so please bear with me. I would like to thank Mary and her team, both former and present, including Andrea, Leslie, Trish, Sue, and Stephen, who were always willing to think outside of the box. I would like to thank Mike, Hashem, Elam, Naz, Margaret, George, and the late Ferg Mills. I'd like to thank the Canadian Thoracic Society leadership team, both former and current, Janet, Cheryl, Dr. Butani, Dr. Hernandez, Dr. Barbeau, Dr. Marciniak. Through the years, there have been some very special people that have contributed their time and energy to our goal, and I need to thank Jessica, Mikhail, Peter, and our dear friend and colleague, Jane Duke, who is here with us today. The Alpha-1 patient community is a diverse group of patients and caregivers, and I'm sincerely humbled to have had the opportunity to get to know many of you on this journey. I know that sentiment is echoed by our friends and colleagues at AlphaNet Canada, and I'd like to thank Mark, Mike, and John for taking the time to come to Calgary this weekend, and to Bob Green and the AlphaNet board for their unwavering support, not to mention Dr. Sandy Sandhouse, who has cheered me on since day one and I'm sure is watching online. I'd like to thank the cheerleaders, the donors, the supporters, and even the doubters that fueled this initiative, because I'm truly grateful for each and every one of you. In closing, I think it goes without saying that the work that has been done to get to this point could not have been done without the patient community's generosity. And in that vein, I'd like to request that you consider Alpha-1 Canada your charity of choice this holiday season. I could go on and thank Dr. Ken Chapman for again indulging me for over 6 years and answering all of my calls and emails, which is something and a lot of doctors don't do. So thank you, Ken. I'm going to try not to cry. On behalf of all of our guests, the Alpha-1 Canada board, and myself, thank you for joining us today. And we look forward to continuing to improve the life of alphas in 2024 and beyond. Thank you. I did it.